Hello, and welcome to this week's episode of Medisodes. This week, we're excited to be joined by Dr. Rajs, who's a radiologist who also has an interest in AI. Thank you for joining us today, Dr. Das. Could you explain what your job entails on a day-to-day basis?
Yeah, thank you for inviting me, Shrey, on this really excellent podcast. I've listened to some of the previous episodes, and it's really great your team are doing this. So yeah, no, thank you for inviting me. So I'm a radiologist. So radiologists are essentially doctors that specialize in expertise in imaging. So firstly, I mean, I went to med school, and then after med school, I did my foundation training for 2 years, after which I actually initially wanted to be a physician. So I did some training in medicine for 2 years. And at that time, I wasn't sure whether I wanted to pursue careers in general medicine. I thought about doing oncology for a bit. But I think in the end, I decided to apply for radiology. I felt radiology was a field that was very rapidly evolving. And I think that I was quite excited by technology. I'm quite techie generally as a person as well. And I felt it's quite a good balance between, if you like, medicine and engineering, so it's an Indian parent's dream. You've got a son who's a doctor and an engineer at the same time. So I felt it was quite a nice field, and it was ever changing. And also radiology gives you the opportunity to also do, if you like, a minor surgery called intervention, where you use the help of imaging technology to guide procedures. And so that's the field called intervention radiology. So I went into radiology training, which is another 5 years, and that I did in Birmingham. And then at the end of my training, I became a consultant. Before I became a consultant, I did a year, what we call a fellowship, which is kind of an expertise training, which I did in Canada in a place called Edmonton, which is a very cold part of Canada, but it had a really good cardiac centre. So one of my areas of interest is cardiac imaging. So I trained in cardiac and chest imaging, and now I'm a consultant at Leicester, a hospital called Glenfield, which is kind of a specialist hospital dealing mainly with heart and lung problems. And yeah, I've been a consultant there for 5 years.
Okay, so from that, so in terms of your day-to-day, would you say it's mostly what kind of things you're doing on a day-to-day basis rather than as an overview?
Yeah, so the typical kind of job plan of a radiologist. So for me, I am more of what we call a diagnostic radiologist. So I do less intervention and more interpretation of imaging. So the average week, I do, so on a Monday, I do something called lung biopsies. So basically, that's my kind of main source of intervention, where I use the help of a CT scanner to guide a needle into the lung to take tissue from any potential lung cancers, and that's kind of my Monday morning. And then over the rest of the week, I have 4-hour sessions. Your job is divided to kind of 4-hour blocks of some of it will be reporting CT scans and interpreting CT scans. Some of it will be reporting MRI scans, and then some of it's looking at chest X-rays. A lot of it's involved in meetings with other disciplines. So because obviously with any kind of diagnosis, the diagnosis on imaging, you only get one perspective. So it's always important to discuss your diagnoses with other clinicians who have obviously different angles of looking at the patient. So then you can obviously give a much accurate diagnosis. And then I have an ultrasound session. So ultrasound is also part of radiology as well. And that's pretty much it. So week to week, Monday to Friday, it's primarily 9 to 5. And again, most of my week is in reporting, so looking at images, interpreting images.
Yeah, so you've discussed your general day-to-day job, but over the last 2 years, we've switched more to working from home due to COVID. So to what extent has COVID impacted your job?
Well, it has, I think, and I think radiology's been quite lucky because we're one of the few specialities within medicine where you can work from home particularly with reporting workstations. So the first thing our hospital did was they identified people who are more high risk or vulnerable group within the radiology department, the elderly people who had underlying health conditions, and they essentially gave them home packs. So PACS is our kind of system, if you like, that we use for reporting. And so all of that reporting was done for them from home. And the rest of us we were given home packs facility where we could do some of it from home, some of it away. And obviously we had to ensure that our home was a safe environment, that we kept data confidential. We had to go through certain levels of, most of the home pack solutions are what we call VPN. So we have to use a password to log in to the server at the hospital, which makes it quite safe. But yeah, I mean, it's the pandemic has been quite tough because imaging was one of the few things in the first wave, at least, which stopped unless it was for acute emergencies. But at the same time, pretty much most acute admissions with COVID had chest imaging, which is what my area is. So almost everybody had a chest X-ray that came in with breathlessness with COVID. A lot of patients had CTs of the chest. And so we had to keep on top of that, reporting through the day, through the night. But with home packs, we were able to do a lot of that from home. And then, like with all hospitals in the country, because the impact was so much on the frontline staff, particularly people in ITU and A&E, a lot of our trainees, particularly, and some consultants were redeployed. So we had to work in ITU and A&E for a little bit to help out our colleagues. A lot of them were in more kind of nursing roles, but because we've kind of lost the day-to-day skill of that the experts in ITU and places like that have, things like intubation and stuff. But we can still help out. We can still help moving patients and do basic observations that we learned at med school. So yeah, some of us were redeployed, but overall, I think we transitioned quite well through the pandemic because we could work a lot from home.
Yeah, so you've compared the two styles of working before the pandemic and after. So which would you prefer? Do you think working from home is effective, or do you think
Yeah,
a
so
return to work is
actually,
better?
and I'm sure you found the same with speaking to other specialities, that I think before the pandemic, there was a lot of red tape about home working and about how we're going to manage this, what about this, what about that. But actually, the situation forced home working on us when we had no other choice. And actually, what it has allowed is that it's allowed people to have a balanced life. I think that, at least for me, I find reporting, particularly outpatient work, where I don't need to be near and around the patient. I prefer to do that from home because I get less interrupted. I'm not constantly people not knocking on my door for advice on things or things to sort out. And the less interruption you get, obviously, the more you are focused on your work, potentially less mistakes. And so I now work a day a week from home, where I do the bulk of my reporting. And I prefer that. I'm actually more productive and I feel that I'm in a safer environment at home. And also, it's a very sedentary job sometimes, looking at scans and things. But actually, at home, it gives me a chance to maybe go for a run midway, or maybe just balance my hours a little bit better, so I feel more mentally focused on my work. But at the same time, I don't think I would be able to. Obviously, I can't do the intervention from home, but even a lot of the diagnostic work, I sometimes prefer to be quite hands-on. And so I think the 3+2 seems to be the favoured future for radiology, that you have kind of 3 days at work, where you're doing teaching, more supervised work, intervention, ultrasound, and the 2 days you do more of the cold reporting, if you like, the outpatient work. And I think that provides you the balance.
So this is a question more related to your job specifically. So what other kinds of imaging and scans you use to diagnose patients in your job?
Yeah, so I think, like with all areas of medicine, radiology, because it is expanding so much, both in terms of the number of imaging technologies, but also the number of scans we do. And So we've all had to specialize. And so my areas of interest are chest and heart. And so within those, we've seen a huge expansion in CT and MRI particularly. So, for instance, I would say in the last 10 years, there's been a big expansion in heart CT, what we call CT choreangiography or cardiac CT. So the CT scanner is basically, if you like, a glorified X-ray machine. It's a huge machine that has, multiple X-ray sources directed at the patient to produce a three-dimensional image. And in the olden days, scanners were just so slow that the heart was really blurry, so you couldn't really image the heart very well. But now the scanners are so fast that you can actually image the whole heart while it's resting in between heartbeats in the diastolic phase, if you like. And you can see the blood supply to the heart. And in the older days, the only way you could see the blood supply to the heart, look at coronary arteries, was by doing an angiogram, which we would inject a dye, and it was a full kind of inpatient procedure, if you like. But now you can look at those coronary arteries with a CT scan, which is quite amazing, really. So that's one of my main areas of interest. There's a lot of research in that particular field as well. And then there's MRI scans, which use the principles of magnetization, and essentially the big magnet will flick the hydrogen atoms within the thing you're scanning, and when they relax, they release a kind of signal, and that signal can be translated to an image. So it's, again, really clever technology, and that's really come leaps and bounds. The big advantage of MRIs is no radiation. And MRI, in my field, I use it for heart MRI, cardiac MRI. And again, it gives you very good functional data. It shows you how the heart contracts, whether there's any heart failure, whether there's any scar in the muscle. And particularly now during COVID, I think we've used it a lot to look at things like the impact of COVID on the heart with things like myocarditis, which is an inflammation of the heart that can be associated with COVID. And much, much, much less commonly with vaccines, but we do look at that as well with the cardiac MRI. So that's been really important during the pandemic as well. And yeah, there's so many modalities that I could just talk on forever, but the main ones are X-ray, CT, MRI, and ultrasound. Those are the kind of workhorse modalities of.
So along with all this new technology, obviously the thing that you're getting most interesting at the moment is AI. So a lot of people have heard about AI and like machine learning and related terms, but could you explain exactly what it is? What is AI?
Yeah, so this is kind of so in the last kind of so going back kind of last 30 years to 10 years, that period, most of the research in the field of radiology was in hardware. So improving hardware, improving scanners, and making scanners faster, more accurate, more spatial resolution. But particularly in the last, I would say, 5 or 6 years, there's been a massive expansion in research in artificial intelligence. So it's automated recognition of imaging, automated reporting, things like that. Now, so artificial intelligence is kind of a broad term, just to define essentially the roles that you would expect a human to do. So a machine essentially thinking like a human. So the task you would normally expect a human to do is done by a software or a computer. Machine learning is a part of artificial intelligence where you use data that is fed into an algorithm or a software or a product, and the machine then learns based on that data, auto-learns and improves. And we don't provide that improvement. It's given data, and then it's basically makes an assessment, and we give it the outcome, which is most of the time we do. We say, well, with this data, the outcome's this. Try and figure out how it's got to the outcome. And then if it figures out how it's got to the outcome, then we feed it more data to improve the algorithm. So that's kind of machine learning. And then deep learning is the other phrase that's used a lot, which is a type of machine learning, which is really kind of the big hot thing nowadays, which is the use of a machine learning algorithm that is based upon what we call neural networks. So it's essentially layers and layers and layers of networks that that try and piece out the data by looking at more and more and more and more sub-segments of the data to be able to reach an outcome. So, for instance, and that's used a lot with things like facial recognition and deep learning. You're kind of structuring a kind of pseudo brain, if you like, with neurons. So it's modeled on the neuronal system of the brain, if you like. And that's really picked up more because we now have the computational power to do that with newer machines and newer computers. And it's probably the one area which is the most exciting, and it's really revolutionized, or potentially can revolutionize a lot of image recognition, even within radiology, but also within other fields of medicine, such as dermatology and ophthalmology and things like that. So that's a kind of broad definition. So.
Yeah, so you've discussed, so thanks for your definition of AI and what made you interested in AI. So, to what extent does a doctor contribute to the development of AI? Because AI is a very computing-based field, and medicine and computing are somewhat associated to be different. So, how does a doctor play a role in this development?
Yeah, so I think that's a very interesting question, and the answer is it's still not very well defined. I think there is to what extent. So in my field in radiology, AI probably is having one of the biggest impacts out of all fields. And so we do ask ourselves, I ask myself this question, is how much computer science do I need to know in order to help me help technology be able to diagnose cancers earlier or more accurately, or be able to do things, to do my tasks more productively. And I think that you can only know so much. I think that the important thing is that the problems need to be identified by the people with the most domain expertise. So what I mean by that is to say, if I have a problem that I recognize as a doctor, so for instance, I find that us as doctors, we miss cancers in this particular area of a chest x-ray because it's behind the heart. So if we could have a technology that can help us identify that part behind the heart better than us, then I'm happy to help that software company or that research university to develop a product that can do that. Now, the problem happens sometimes when the technologies develop the algorithm for another problem, and they try and force fit the algorithm onto other clinical problems. And this is where the problem arises. I think that what doctors can really do is help really define the clinical problem, and say, no, hold on a second, this isn't really appropriate for this, because with our experience, we've seen that this can fail if it was designed to do this and that. So there is certainly, particularly in America, where a lot of, as you know, medics people do medicine after having done a degree before. So you do get a lot of software engineers, mathematics graduates, then applying to medicine, and they themselves know how to code. They know how to produce their own algorithms, and they apply it, to their day-to-day work and stuff. But I think what you really need is a good team, and you need to have. So if I were to think of an idea, what I would want is a team which comprises ideally a computer engineer, somewhere who's very good at analyzing data, a research link within the university that can help us with any research grants or with any research design, and you need all of them. And so the best kind of areas where I would say holistic research is done within AI and medicine is places like Stanford, where they have just amazing teams of doctors, of computer scientists, of AI experts working together, solve a common problem. And I think that's the ideal model. I don't think it's necessary for you to really learn computer science, but I do think it helps, particularly if you want to do radiology, to have an understanding of the basics of AI, to have an understanding, maybe even learn a language like Python, to have an understanding of how you would get to kind of some bits of the clinical problem and how you would start to code something like that. And then you obviously need domain experts. I can't pretend to be a computer expert, having been a doctor for 20 years, and neither can a computer scientist pretend to be a doctor, having studied for 1 year. It's just not possible. Everyone has to respect each other. But I think the outcome has to be the patient. The patient's the most important thing at the end of the day. And AI has a lot of problems and challenges, which I can come on to next. But those have to be addressed before you can go any further. And you need to be in the same team and have the same beliefs for that.
So as you said right now, there are many challenges to implementing new technology. So what are some of the challenges in implementing AI in radiology? And when it comes to accountability and responsibility, who would you say takes most of the responsibility for that?
Okay, yeah, so that's a really good question. So I would say that the problems with implementation of technology, for instance, AI, I would say there's lots of them, but there are probably about 3 or 4 main groups. So the first big issue is data. So that's both in terms of how applicable the technology is. So the data needs to be representative of the population that you want to use it on. So there can't be any data bias. So one of the reasons people talk about AI being really revolutionary is that the AI scientists believe that the AI will be less biased than a human. So humans suffer from something called heuristic biases. So for instance, there was a study that was done where people looked at how many people were diagnosed with heart attacks in America who came in with chest pain into their emergency department. And they found that men who were under the age of 40 had a number 1 diagnosis of heart attacks substantially less than people who were just over the age of 40. There was kind of a graph that went like that. And it's because traditionally we were taught med school that under the age of 40, heart attacks are less common. But there's no logic to that. Obviously, life is not black and white, it's a spectrum. But these are kind of biases that all doctors inherently have, and they try and avoid as best as possible. They try and be as objective as possible. But sometimes you do kind of go back because you're trying to work out So AI will not look at those traditional biases, and it will look at things more as a spectrum, like a probability map, if you like. But at the same time, if you feed data into an algorithm which is all of a certain ethnicity or a certain age or a certain sex, then you certainly can't be sure that can apply to the general population. And these biases do exist. So you need to make sure the data is representative of the population that you want to use it on. That's number 1. Number 2 is data governance. So who owns the data? How do we know the data is protected? How do we ensure that the data isn't used by third parties, or it doesn't go to Facebook or someone like that without our consent? So then the question is about, is data that's anonymous truly anonymous? These are kind of ethical discussions. There's no right answer to these things. But at the moment in the UK, data of patients is owned by the hospital. So the hospital has the ownership of that data. And when we work with AI companies, we ensure 3 or 4 principles are held: that the data is used is not shared to any third parties. The data has several layers of anonymization, so we know not just 1, but sometimes 2 or 3, to ensure that can never be tracked back to the person. That any data that is used externally to develop a project is deleted. So once it's being used to develop that product, it doesn't stay on their database, so it can be breached or gone over. And so these are called kind of DPIA forms, which companies have to sign to ensure we allow them to work with them. But that might change. So in some countries, like Latvia, for instance, the patients own data. So some countries, it's the patients that own so they can do what they want with it. If they say, the company approaches them and say, well, we want to do research on your data to develop our product, they can give that data to that company, and then it becomes a personal choice. And these are kind of probably national debates that we will need to have in the next 10 to 20 years going forward. So data governance, but it's really important for that bit. Then the third thing about data is we need to ensure that we're always engaging patients, because this is for their benefit. So we have focus groups. We've created these in Leicester that we have kind of 500 maybe or 1,000 random people picked to say, look, we want to detect cancer early because this is. However, for us to do that, we will have to work with some companies, and it may be the case that we will have to share your data, but it may be anonymous, and we will ensure that it's protected and all that. Would you be happy for this if it's in the benefit of society? If you feel that, and so then if they say no, I think it's a good thing, and we got the support of the patients groups to say no, and then at least then we know that we're working in the best interest of patients, not just in the best interest of us as clinicians or as businesses. So that's data governance. Then there is the second issue, which is when it makes a mistake, who takes accountability? So then there's an issue called explainability, which again is a whole field within AI in its own right. Now, if I make a mistake as a doctor, there's a clear chain of command, that I made the mistake because I was too tired and therefore I prescribed the wrong drug. Or in radiology, I made a mistake because that time I was so busy, I didn't get to look at that review area, that top right-hand corner of the screen, and therefore I didn't see the abnormality. And then and everyone makes mistakes. And radiologists are a little bit like goalkeepers, if you like. We're expected to make the saves, but everyone kind of focuses on us when we've made that one mistake out of, even though we've saved 100 goals. So, and it's just the same. So then you have, but everything's black and white. So then you say, right, in future, I will ensure that I make sure that I review that area in the future. And then you've got a chain of kind of, why you made the mistake. The trust pays out, reliability, if that's relevant. With AI, the AI is not going to explain to you how it made the mistake. It's just going to say it didn't spot the abnormality. So I think what you'll need to have is at least a recognition that if the algorithm is fed the same problem again, it's not going to make the same mistake again. So I think if it manages to do that, so AI is quite good when you've got lots of data, so really common stuff. So I don't know, 70% chest X-rays we report are normal, for instance. So in terms of excluding normality, an AI might be really good. But in terms of if you've got an abnormality there's only 10 in the whole world, then you can't train the data set with just 10. A human is more intelligent to know that this is something completely unusual. Whatever it is, it's abnormal. But an AI may read that completely differently. It may, just because it's not seen it may call it normal, abnormal, but it won't really know what it is. And it's the same example of, you could test a Tesla, to stop when it sees something, but you can't test it to stop when it sees a giraffe because it's never been tested against a giraffe, but you hope it will see that. So it's the same kind of thing. It's the kind of, but I think the accountability side of things needs work, I think. And in terms of who takes the liability, again, very good question. We don't really know. And I think at the moment, if we, as a hospital, if we use a particular product for the purposes it's intended to do, then it's the trust or the hospital trust that has to take the liability, because it's made the risk analysis say that we have employed this company purely for the basis that we believe that we can, and in the same way as the trust takes liability for a doctor making a mistake. So it will judge AI on the same standards. But the difference is a doctor can say, can say, I'm sorry, or can have that duty of candor to the patient and speak to the patient, say, look, this is what happened, we'll make sure it doesn't happen again. Whereas a machine can't do that, and some patients may not like that, the fact that there is no direct communication with an individual, that it has to happen at a trust level. So those are some of the main challenges, I think. Data governance, the fairness of data, the explainability, and I think, like I mentioned before, the clinical problems. Many of the time, the data scientists, obviously, and the companies, they want to do what's best for society, but obviously they want to make money as well. They want to become a big startup. They want to invent something that's transformative. So they're ambitious, and rightly so. But I think that ultimately, the people that control the data and the clinical problems and the patients should control the narrative. They should be saying, okay, so sometimes the problems may not be as sexy, if you like. They may not be as, it might be something to do with vetting. So as a radiologist, before I know if someone needs a scan, I need to look at the clinical indication and agree that scan is required. So that's a process called vetting. And that is a very boring process. It has to be done. Because we have to justify ionizing radiation, make sure the test is the correct test for a patient to acquire the test. It's a manual process. But if there's an NLP software or natural language processing software that can read a request card, that can judge whether a scan is needed, and that can save us 80% of time, that might be a better use of AI today than something that can automatically read a scan. So it's important to control the narrative of the clinical problem. Yes, I guess those are the main challenges, really.
I was just wondering, we're talking about implementing AI. So with other interventions, obviously, there's like RCTs, there's randomized control trials and stuff like that. But how is AI actually tested to make sure it's correct, apart from like just feeding it loads of data?
Yeah, so, and again, this is one of the things where I think we're going to see a change in the next few years. A lot of the data that AI uses to test its algorithm is, it's retrospective data. So it will look at huge databases and it will say, well, based on looking at this database, our algorithm is X accurate. As we know, in the real world, if you want to really believe something works and makes an impact, the best form of evidence is evidence where you have a control group and it's tested prospectively in real time. And ideally, it's randomized. That you maybe even blinded, so you're not even aware that you're using an AI product. And for that, obviously, you need to go through ethics and things. And there's not enough of that at the moment. And I think, we're working towards one project in our hospital where we're trying to produce a prospective RCT using AI against standard of care. And I think there needs to be more of these. And there will be, and that's what's growing. I think where you have AI versus standard of care or AI versus a control group, because that's when really people are going to believe how good it is. Because the problem with retrospective data is it depends on the data. If you have a population of abnormals, if you have let's suppose you're looking at X-rays again and say 100 X-rays of which one is abnormal and 99 are normal. And let's suppose that's the normal distribution in a certain population because it's, say, a screening population, they're not symptomatic. So X-rays are, say, done for screening for things like TB and other diseases. And then the company said, oh, look at our algorithm, we've got 99% accuracy because, but actually, if you just had an algorithm that just said normal to every single X-ray in that group, it would still have a 99% accuracy. So because there's only one abnormality. So I think, and we just need to be careful. So when we interpret data from companies, we need to be careful that it doesn't have these things, these terms called like class inference, I think it's called, where you need to ensure class imbalance, where you need to ensure that the ratio of that abnormality is sufficient for it to be justifiable as technology. And for me, retrospective data alone isn't enough for me to believe in technology. It needs to have prospective data, RCT data, if it's really to be revolutionary, as they say it wants to be.
Yeah, so I guess after all that, in the end, do you think that AI in the future, as it develops, do you think it'll ever be able to replace what you do as a radiologist? Or do you think it'll become a tool in the same way that a CT scan or MRI scanner is a tool to help you do your job better?
Yeah, I mean, the thing is, who knows what the future holds? But my personal belief is that radiologists that use AI are likely to replace radiologists that don't. Because I just think that, and the same ways that, in some ways, it's like using an autopilot on one of the newer cars. You know, if humans get tired, humans make mistakes, and what you want is you want the technology to stop you from crashing when you fall asleep by mistake, or you make a mistake, or you, and I think if it can do that, then I think it succeeded in its first role. In terms of what our role is going to be as a radiologist, I think that maybe in the next 10, 20 years, what's probably going to happen is that we will probably be doing more complex tasks where less data is available, and we'll allow the technology to do more kind of mundane, repetitive tasks. But to get to that stage, we still need to test the algorithms, and we need to make sure we're happy with them, they work. And for that, there needs to be a huge amount of work done by radiologists alongside technology, and it has to be a collaborative approach. It can't be one or the other. And for that also we need time, because particularly in this country, there's a massive, massive shortage of radiologists. You know, considering the amount of scans we do, we've just not grown as a speciality as much as the demand has grown. And so our work is very precious. So for us to then spend time doing research, developing technology, but I think that it's a time where we need to do it, because if we don't, then we'll find once patients start owning data, then we may be in competition, which we don't want to be. You know, we want to be collaborative. So I don't think it will replace humans, and I think obviously there's always hands-on skills. So the manual dexterity of things like robots and things is behind the software. So I think, to replace, it might replace basic image recognition, but it won't replace the interventional radiology, at least for another 50 years, I don't believe. So as long as there's always hands-on skill in your job and there's patient-facing, but I think I'm hoping actually that what Eric Topol, who's a huge leader in technology innovation, he's a cardiologist in America, has written extensively on AI. I think what he said is quite interesting. He's got a book called Deep Medicine, which is one of the best books I've read about what he believes is the importance of AI and technology. And he kind of said that the ideal situation is to make medicine more human again. So a lot of our time we'd spend doing a mundane admin jobs, doing, filling in forms, documenting stuff, doing all the admin tasks, doing the mundane repetitive tasks. But actually, if the technology allows us to remove that, where we actually become more, as a radiologist, I would love to be more patient facing now. Patients at the moment, if I report a scan, it will be, the scan results will be conveyed to the patient, sometimes by a GP who doesn't have an understanding of how the scan is, how I've reported the scan. They'll have an understanding of the medicine, but actually, what ideally I would like to do is go through a scan with a patient. But at the moment, I just don't have time when I'm reporting 30, 40 scans in a session. But if I report 10 scans and actually let the AI do 90% of the work for the other 20, which I can just double read quickly, then it just gives me more time to just spend time with patients to bring in them. And there's a lot of evidence to suggest that scans improve diagnostic certainty, but also they reassure patients, they help compliance. If someone has emphysema in their lungs or evidence of coronary artery disease, which I can show them on a CT that these are your lungs and that's what the damage that's been caused by the smoking that you've done, or by so there's evidence to say they're more likely to comply with smoking cessation because it's a picture of themselves, rather than a GP telling them or a physician telling them, your cholesterol's a bit high, you just need to cut down a little bit, or you need to be on a statin or a drug that helps cholesterol. So the impact of images, I feel, can be quite transformative for a patient. So yeah, so that's where I hope AI will take us. They make us more patient-facing, make us more empathetic in terms of getting more involved with patients, which is the things that AI can't do. You know, they can't be empathetic. So